So we think there could be probably a wind wiper micro effect. So 2 of these 9 patients underwent revision, and the one on the right shows the failure, and my colleague BJ Singh has also had 1 or 2 failures due to this holding suture having just lost. So there are 2 more patients awaiting revision. So I think basically using the tightrope of the graft rope has a cautionary tale to it, that you get stretching or a wind wiper effect, and you do get this thing potentially failing. So surgeons should be wary of this, really. Okay, so just to summarize what I tend to do: grade 1, symptomatic treatment; grade 2, sling for 2 weeks; SOS, injection out of physiotherapy; and then SOS, a Mumford procedure if they are highly symptomatic and fairly active. And I would probably do that through a small mini incision and repair the superior and posterior AC ligaments. If it's grade 3, I use the same algorithm. So you try functional rehab if they are not an athlete or high-level sportsman, and then if they yet have symptoms, then probably consider surgery. 4 and 5, you probably go for surgery right from the beginning. Now use the Surgilig or the lockdown, and on its own in younger patients less than 60, but combined with CA ligament reinforcement in older patients, because I think there you can add an augment with the CA ligament, which can be quite useful. Grade 6, extremely rare, but if you get that, you do need to do an open reduction and stabilization. Thank you very much. This is where we come from.
Okay, thank you. I'd like to talk about Lisfranc injuries, especially of the ligamentous type today. Lisfranc was a French surgeon in the Napoleon's army, as you probably know. He performed only TMT amputations and never fixed any fracture dislocation at that time, but he was associated with the joint level. It starts as a minor sprain and can progress to unstable injuries and finally fracture dislocation. The joint is stabilized by bone as well as ligament supports, and the nature of the arch, what we call as a Roman arch, is the key to the stability, with the keystone being the second metatarsal and tarsal-metatarsal junction. The ligaments, again you have transverse, dorsal and plantar ligaments, but there is no transverse ligament between the first and second. You have oblique plant ligaments, so it's an area of relative weakness, and it's from second metatarsal to medial cuneiform. You have dorsal, plantar and interosseous being the strongest ligament. The plantar ligament, as you can see, on that side is reinforced by plantar fascia and intrinsic musculature. Had to think columns in this joint. The medial side has about 3.5 degrees of movement. The middle column, second and third metatarsals, has very little movement, but the lateral column is very mobile, and that's why we want to preserve this, and we want to use only wires and not screws ideally. It's only a 0.2% of all the fractures, but it's commonly seen in polytrauma patients, and more than 20% can be missed. It is increasingly seen in athletic population, especially the subtle variety. So can just the ligament injury lead to instability? The answer is yes. If you do just isolated sectioning in the cadavers, it shows diastasis at this joint. The basic message is to have a high index of suspicion, and there is no such thing as simple midfoot sprain. The mechanism of injury can be direct, and the dislocation can occur either dorsal or plantar, depending on the direction of the force. This is due to the weaker dorsal ligaments. And it can be indirect, where the axial force is applied to the plantarflex foot, and again the dorsal ligaments rupture and the dislocation happens. There is often inversion and eversion component. The most common mechanisms in the indirect injury could be fall from height, missing a step, this is a classic pattern, road traffic accident, and of course athletic injuries. Again, you should have a high index of suspicion. It's not just a foot sprain, so you have to be wary of the description. Patients are often unable to weight bear, and there is this classic plantar ecchymosis, and there is disproportionate pain and swelling. More than 90% of the patients have this flex sign. As you can see, it's a small avulsion fracture at the base of second metatarsal. And in the AP view, you had to follow this line of second metatarsal to middle cuneiform. It should be straight without any steps. The second line is the fourth metatarsal to the cuboid. These are some examples where you can see minor subluxation to frank fracture dislocation. CT scan is very good for bony anatomy. You can see the diastasis as well as avulsion fractures. But the MRI gives you the soft tissue definition clearly. And if you have an injury to the plantar ligament, it's the strongest predictor of instability. The subtle injuries or the ligamentous type is common these days due to sports and often missed, and the radiographs do not always say the true story, and this can form almost 40 to 50% of all midfoot injuries or the less frank injuries. Treatment is still undecided. And these are the views. If you take an X-ray without weight bearing, you don't see much diastasis, but if you make them weight bear, you can see the gap increasing. So I would recommend bilateral standing views and look for, and the second line you look for is the distance between the medial cuneiform and the fifth metatarsal in the lateral view. So the first picture describes how there is a positive value between the cuneiform and the fifth metatarsal, and the second one, due to collapse in the arch, this value is reversed, it goes into a negative value. And if you're still not sure, we can always perform examination and anesthesia or simply local anesthetic and stress views. In this one we do the adduction, and then in this you do the abduction, and there's only a tiny bit of difference, but there's no serious subluxation, so this will be quite useful. The classifications are mainly for the bone injuries, but I'll just say that for completions, you have the Hardcastle classification from 1980s. You have total, partial, and divergent types, and this is modified by Meyerson. Unfortunately, the injuries don't read this textbook, so they never follow this pattern. The new one is by Nunley and Vertulo. You have three types in this. First one is a simple sprain, and there is no diastasis. Second one, you have rupture of the ligament with diastasis between 2 to 5 millimeters, but the arch is still intact. And the third one, you have rupture, diastasis, and loss of the arch. And this picture describes it again nicely. So you have just a sprain, rupture and diastasis, and you have rupture, diastasis, and the collapse which we saw earlier. Okay, the treatment is very important. So accurate reduction and fixation will produce better outcome than delayed salvage procedures. So often consider associated injuries, compartment syndrome in some cases. The swelling is an important problem because either you can do very early or in 7 to 10 days time. So all these options are there, but the first four are not good. So you either want to consider open reduction internal fixation, or in some cases where there is severe damage to the joint, you can have to do fusion. But open internal fixation is a good option in many patients. The gold standard is reduction with emphasis on the reduction. So if you achieve anatomic reduction, the results are good to excellent in nearly 80 to 90% of the cases. Whereas if the reduction is poor, you have a high chance of arthrosis. Quite often you end up doing open reduction to help the soft tissue out of the area and sometimes excise or fix the fragments. K-wires are considered unacceptable except in the fourth and fifth metatarsals. The screw fixation provides rigid fixation and avoids redisplacement, and you can start relatively early weight bearing. And there's not particularly increased risk of infection in this. Okay. What is the outcome? So Even with good reduction and appropriate treatment, 25% of patients may develop arthritis, and some end up in arthritis. So aim for anatomic reduction, but the ligamentous injuries may lead to poor outcomes compared to the bone injuries. And in this article, you see nearly 40% of them have just ligamentous injury and they have high arthritis changes. And this article is quite widely quoted by Chris Coetzee and Lee. They performed primary fusions for purely ligamentous injuries. You may have avulsion, but there is no major damage to the articular surface. But Chris said, following the study, that they do better with the primary arthrodesis of the second and third joint if necessary. And except this study, there's nobody else could produce that. In the recent time when I asked him, he said he still performs some, but more for the damaged articular surface than these injuries now is my feeling. So in this one, the case of a rugby player, he limped off. He had swelling in the midfoot, but not sure about the bruising. And if this is the only X-ray, we may not appreciate what's going on. And if you see comparative views, you can see there's a big gap on the second TMT joint. And this again shows a tiny step at the level. So in summary, the 3 R's you have to remember is recognition of this injury, appropriate reduction, and rigid fixation. And the stabilization often can be with the screws like this, and the oblique screw between the medial cuneiform and the second metatarsal joint is the important screw. It replaces the damaged plantar Lisfranc ligament. Sometimes you need bridging plate if you have comminuted fractures in the base. Usually 2 weeks of casting, and then you can keep them in a boot or a removable splint. Start weight bearing at 6 weeks and progress as tolerated. Ideally remove the screws around 4 months. What do you do in case of missed injuries? If you see them within 2 to 3 months, you can consider reduction and stabilization. But after that, you may have to decide on patient symptoms. You may treat them with shoe modifications, orthotics, or go for fusion at that stage. When do you remove the metal work? There is no consensus, and I prefer to remove them at 4 months because I feel they have a little bit improvement at that stage. Thank you. Some of the slides are from Dr. Bellet, a friend in Columbus. Thank you very much.
To come and give his talk.
Yeah.
First one?
Yeah, that's one.
No, if you may.
Version 3 is the one I loaded last. Okay.
This one?
Okay.
Okay.
Yeah, that's fine. Good evening, and thanks for exclusive audience. It's a rather big topic to cover in a 10-minute talk, but I'll do my best. Basically, I think it's important that we have the foundation right before we're building something on it. So we've got to ask ourselves the question, why do we have a complex anatomy in the foot, arches and multiple joints? Why do flat feet and cavus feet hurt? Why do these deformities occur in the same first place, and how to treat them? I think if you can walk away today understanding a simple concept of springs which we see in automobiles, I think that would give a better understanding later on in foot and ankle surgery. So we have a medial arch because it's similar to a spring in a truck, a leaf spring. So you turn it 180 degrees and that's your foot. We take it for granted when we walk that we just do it without thinking about the springs. Every step in the mid stance it sinks down and then it recoils exactly like a truck spring. And a flat foot is essentially a spring which is collapsed. And it depends on ligaments and tendons. You'll hear more about it. The other part of it is the reason for multiple joints all close together, packed together. I think God was a genius or is a genius, and it's the same philosophy that follows a multi-link suspension in a car. Your wheel can go as shown in the slide in all directions, And that's exactly what happens up and down, side to side, and rotation. And that lets us function like a four-wheel drive. You can run up a hill and so on. And again, that's put under a lot of stress over 80 years. A car doesn't have to last that long, but our foot has to. So sometimes it does wear out. And the caver's foot is really a stiff suspension. We'll talk more about it. So next time, look at your feet, think you've got two sports cars under them. So that's a combination of a leaf spring and a multi-link suspension. Now, to understand how it works, it's a very complex movement. Everything focuses around this area, the subtalar joint, and they're not, the talus and the calcaneum are oriented in an odd way so that when one moves down, which is the talus, the other moves up and out, and that's what you just saw there, and that's the basis of a flat foot. So in other words, I'll go back and play it again. If you see there, that's a flat foot where the calcaneum tilts out and the talus drops down and medially. Now, what happens in a caver's foot? It's the opposite. The actual calcaneum tilts in and the talus rises up rather than plantarflexing until spins out. And that happens every single time you and I walk as well. But this is an extreme end. It's stuck in that extreme end. That's the only difference. And let's go on to another special feature of the anatomy. Now, the talus is a unique bone. It's suspended in mid-space. It's unique because no muscles are attached to it, and unlike the other bones which are controlled by these muscles, this just floats in the air with no direct attachment. Now, there are two sets of attachments. Each one of these do play an important role in the development of both the cavus and the flat foot. Now, you have dynamic attachments and static attachments. Very simply, they are like on a flagpole, you have stay wires, it's the same thing. So they work around the bone but are not actually attached to it. And if they give way, the ligaments and tendons, then you have problem. Right, let's go on to flat feet. Now, in terms of pediatric flat feet, it's completely different to adult flat feet. And it's important to have this concept very clear. When in pediatric flat feet, it's all to do with the ligaments around the talus. So if it's lax, so you could have laxity in the upper limbs. Everyone I'm sure knows how to check Baton score. You do the finger check and your elbows bend backwards, knees bend backwards. But you also have a unique feature which we are just about coming to grips with, that just the subtalar joint could be very mobile. So we saw that video where the subtalar joint can be moving one way or the other, and that movement can be excessive. And that kind of patient may not show hyperlaxity elsewhere. He or she may just hyperpronate. Now, there are other factors which don't cause the flat foot but actually make it worse. Walking like Charlie Chaplin, out-toeing gait, or if you have knock knees, everything puts excessive pressure on the medial side, and that promotes flat foot. Lastly, there's a very complex relationship of flat feet and tight Achilles. And this is especially so in children, where if you can't dorsiflex above neutral at the ankle, you evert and do it at the subtalar joint. So the lateral border looks like it's going up, but unfortunately the medial border sinks down, and that causes flat feet. So the only check you need to do when you first see a pediatric patient flat foot, is to determine whether it's a rigid flat foot or a mobile flat foot. I think if you got that picture right, that's half the problem solved. The rigid ones are difficult to treat because they are associated with tarsal coalition and so on. The hyperlax ones are easier, and you just got to see if they have any associated axillary navicular, or as I mentioned earlier, knock knees and out-toeing gait due to femoral retroversion. Now, why does pain occur? A lot of people don't understand or think you can live a full life with just flat feet. That's true for the vast majority, but in its extreme, it can hurt. It's very simple concept. We shouldn't be having callosities there. That's meant to be the spring. If the spring is scraping the road, then the car is going to be an awful place to be. So it's the same thing. This shouldn't actually sink down. And you can see the external rotated foot positioning, and this is a tiptoe test. If the arches form and the heel tilts in, that's a mobile type of flat foot. If the heel doesn't tilt in, then it means it's rigid. So easy to treat the simple ones, which is the mobile. Exercises play a small role. Insoles help as well, building it up on the inside, but obviously it won't create a permanent correction, but it makes life livable if you modify your activities, don't do too many sports. Achilles stretching, very, very important to do it with the foot inverted, otherwise you fall into the trap of again everting while doing the exercise, and that promotes subtalar abnormal movement. Now, surgical options, the gold standard for years for flat foot correction, we are talking children here, is calcaneal lengthening with iliac crest graft. We'll see images later, but it's a very simple dough wedge principle. You want what's tilted into valgus to tilt into varus, and this is what you see here, pre-op picture with the talus pointing down and a severe abduction uncovering. It's like a bowler hat which is slipped on the bald head. That's a talus going down, and we are talking iliac crest graft there. The big arrows show the iliac crest graft. We have cut the calcaneum into two there. The same graft, you can see a triangle, and the idea is that it spins the calcaneum to the opposite side. I've done in this case an additional shift, cut the calcaneum and shifted it medially some more. So you get excellent correction. And if you go back to the pre-op and put a staple there, that creates an arch. So completely offloading what the patient had symptoms from, which is weight bearing on the medial side. This is something in evolution. It's more to complete the picture. Arthroeresis is a term used where an implant is put into the sinus tarsa, which is a natural space we all have, extending into what we call the canal, the tarsal canal there. And this is the evolution. It has a very bad reputation because it used to be made of soft materials like silicon and used to get crushed, and then they had metal ones which just stuck in the sinus tarsa area, which wasn't very stable, used to get pushed out. But the more modern ones, in very selected cases, helps. And as I said, it's an evolution. We have a short series at the Birmingham Children's Hospital. Again, a pre and post-op, you can see clearly how it's pointing down there, and then it's pushed up. It's again acts like a doorstop, preventing it from sinking. And as I said, it's like synchronized swimming, how both these move. So the calcaneum, which is in valgus, also tilts into varus with this. Again, in the AP view, you can just about make out how it's going backwards. 86% satisfaction in a small series, 34 patients, 59 implants. Going on to adult flat feet, completely different issue here. There is nothing wrong with the ligaments. It's something that happens in a normal patient over time. You get acquired, that's why the term acquired flat foot is used. Here the culprit is the tibialis posterior tendon, which slowly degenerates. And earlier stages inflammation, later it's tears, and still later you get arthritis in the subtalar and ankle joint. This is a typical case where you get the too many toes sign, the heel is tilted in the valgus, usually a middle-aged woman with pain over the tibialis posterior and the medial side. So a good arch collapses. Initially you can give injections in physio. Again, it's a temporary relief. If you want permanent relief, you have to replace the torn tendon with a new one, usually use the FDL. And if it's arthritic, then you fuse either the ankle or the subtalar joint. Again, an example of one of these surgeries. There are several ways to do the calcaneal shift, so something tilted out is tilted in. This is a very new procedure called the scarf osteotomy of the calcaneum. You can see a laminar spreader there, spreading it out, and so what that spreading does is it stretches the plantar fascia and creates a small arch. And then in addition, you still tilt it around and tilt it from valgus to varus. The first screw holds it with compression. The second screw, you'll see later, goes along for extra safety. And the idea is still the same, shift it one way or the other, depending on varus or valgus, the heel is shifted. This is the final film showing the same thing, well healed. This is the next stage where you get severe flat foot and arthritis. There's no choice except to do a triple arthrodesis. Now, the last deformity is the opposite one, and most times here, not most time, at least 50% I would say, or 40%, there is a neurological basis for cavus feet. Now, a flat foot collapses due to lax ligament. A cavus foot is the opposite one. It's like a shock absorber which is really wound tight, so it's a very stiff foot. You get clawing, as you all know, and the heel's in varus. there's a neurological basis, like I said, 40 to 50% of them, and usually the first metatarsal comes down because the tibialis anterior is weak, peroneus longus strong. Clawing of the toes occurs because, just like the ulnar claw hand, you get weakness of the intrinsics, and heel varus happens because the tibialis posterior is much stronger than the one that everts it, and equinus results because there's a weak tibialis anterior. Much more commonly you see it in athletes or even recreational sports, people doing recreational sports, where they get recurrent ankle sprains, and you do your Brosnan repair, it comes back again. Again, it's because there's a subtle varus, and these people can also get a stress fracture, and they can get peroneal tendinopathy. So not all cavus feet need to have a rip-roaring cavus and clawing. Surgery in children where the joints are still supple, correctable, you can do only soft tissue procedures, plantar fascia release, tendon transfer, peroneus longus to brevis, and take off the tibialis posterior causing the varus, make it go into valgus. And for the claw toe correction, we do a transfer of the extensor hallucis to the first metatarsal. And for the lesser toes, you can do a flexor to the extensor transfer. In the older patients where the deformity is fixed, you'll have to do again calcaneus osteotomy. You can shift it in different planes up to correct the equinus, shift it, rotate it, and also shift it laterally. For the cavus, the same Jones procedure, but in addition we also lift it up with the dorsiflexion osteotomy. You'll see images shortly which will be more useful. For the claw, you do a PIP fusion while osteotomy, and you've got to tighten the ankle ligaments. There's a little technical tip: when you're trying to do a shift, try and use 2 wires, because when you push it with a thumb or any instrument, it tends to really spring back. So keep it in place with 1 wire and then pass the next screw. Again, shows a post-op result. We've done the osteotomy there to shift from varus to valgus. We've done a dorsiflexion osteotomy, lifted up the first metatarsal, and done a fusion there to correct the claw. And what you can't see, of course, is a tendon of EHL going through a hole there. It's very important to shy away from fusion because this is already a stiff foot. So unless there's arthritis or something totally difficult to correct, don't fuse. Take-home messages now, the final couple of slides. So flat feet in children, think lax ligaments. Flat feet in adult, think tibialis posterior. If it's mild, just insoles. Moderate, we're talking children here, you can do sinus tarsi implants still in evolution, and look at the space, maybe in a year's time we'll have a paper published. And severe ones, you do osteotomies. Flat feet in adults, you got to do a transfer of the tendon, replace the torn tibialis posterior, and do a calcaneal shift. Cavus, try and preserve the joints and do a tendon transfer and osteotomy. Thank you. Any questions?
Thanks, Hari. I've been asked to chair this mini symposium, which I think I've found the title for: failed ligaments, whether they are traumatically damaged or lax. Are there any questions? Do you want to come up, Hari and Ramesh? Okay. Yeah, thank you very much. Oh, you got a question. Sorry, Benno.
Now, about these sinus tarsi implants, what is the best available evidence on this so far, Hari?
Sorry, what's the best available?
What is the best available evidence on this so far?
Not much. It's the designer of the implants, like the various one, they have fantastic results. We are talking like high 80s, 90s, but they've published it in usually a mixture of children, adults, or just adults, where the pathology itself is different, and they shouldn't, in my view anyway, be using it. In children, there is very little evidence, almost none long term. That's why we're doing it as per NICE guidance with formed a protocol, got the clinical governance to approve it, and we've just sent it off for publication. We'll have to wait and see. There is a learning curve, unfortunately, as a result of the fact that nobody can teach you or nobody can tell you what's wrong. There's nothing in literature, but I do feel that there's a role for it, and I feel that 86% can improve to 95 or so because there's a learning curve. You overcorrect or undercorrect quite a few in the initial 4 or 5 cases. Yeah.
I mean, the X-rays look fantastic.
Sorry?
The X-rays produced in BOFA's meetings and in your presentation, they look
Yeah, I
excellent.
think, again, the main thing is not to apply it for everybody. If it's symptomatic but moderate, which means that you can't push the talus that's sunk right to the floor up, but if it's sunk enough to cause symptoms, then it works well in the moderate cases. And there's no reason why it should not work. We've already published a paper on how it works in the Journal of Foot and Ankle Surgery.
Right.
We did a serial CT scan analysis of the canal, the sinus tarsi and the canal, to find out how it seats and why it doesn't cause, you'd think it would cause wear and tear of the bone around, considering you're walking and axial loading is through the implant. But it doesn't happen that way because the grip is between the front and back, anterior and posterior walls, between the middle and the posterior facet. But that's beside the point. But if you understand how it works and if you understand why it doesn't work when it doesn't work, I think it will gradually improve. And Liverpool is doing it now. They'll also hopefully publish in a year. But I think we got to just watch and see. But I don't think it's a disaster. It needs just a mind change, and more importantly, we need to understand it because a few thousand are being put in by podiatrists anyway in England, while we watch quietly the other way.
Thank you.
Thank you. I just wanted to ask Ramesh one question. What's the present status of compartments in the foot? We see the disc injuries and we see obviously soft tissue injuries which lead to a lot of swelling.
Yep.
And one of the things that Meissen and all the people who have worked so much on the foot talk about is compartments, but I believe that is not as
Absolutely right. I think this again people have no agreement or consensus on. It's very difficult to quantify the compartments in the foot, but you often see them with the severe injuries and swelling and blistering. It's a clinical decision, purely clinical decision in this case, and if you're worried about it, you can still do 2 dorsal incisions on the foot and 1 plantar medial incision. That should be more than enough. They mentioned about different incision, but if you're worried, if you had to wait, you can often put external fixator and then release incision on the top and then the plantar side. That will be enough, I think. But it's not a universally accepted concept, the compartments and the compartment syndrome in foot. Okay.
Just one more. How late would you consider an open reduction of a Lisfrank's dislocation?
That's a good question, because quite often we see them missed, and my limit is approximately 3 months. Like in most joint injuries, we think the cartilage has a chance to recover before that time. Tim probably will clarify that. But so if you are in between 2 to 3 months, I think you should try and reduce them and hold them in a good place. I think there's definitely a good chance. Over 3 months, you treat them symptomatically, either with conservative measures or consider primary fusion if they are really bad symptoms. Okay.
Ramesh, do you use a plate for primary fusion of the medial column injuries?
Plate for fusions. I have used more screws and staples than plate, but I think plate gives you a better construct, and you have the locking plates now. And you can also put them in compression, those compression devices. So plate is better. I think we have more options, low profile plates.
Yes.
I would go for plates now.
Thank you.
Tim, any comments? Thank you for coming along.
Would you agree that cartilage survives for about...
No, I enjoyed that very much, actually. For a surgeon that doesn't do much of that, it's really quite sharp. I'd like to ask 3 questions. Why, first of all, the first author, why excise the distal end of the acromion when you're trying to reconstruct it? Why can't you, like they are in the foot, we're trying to maintain and reduce the articular surface? That's the first one. Would you like to answer that?
I think the excision was perhaps more significant when you... Sorry, yeah, Tim. The excision is probably mandatory if you were doing a reconstruction of these untreated grade 4, 5 AC dislocations after 6, 8 weeks, because you get that hypertrophic lateral end, which is almost impossible to replace back in its original position. But when you're treating it in the early stages, and it's acute, you really don't need to take out the lateral end of the clavicle.
Good. Okay, and then Harry, I want to ask you a question. And the reason is because I have pes planus, and I have a wife who's got quite bad pes cavus. And we've been treated conservatively throughout our lives, and we are fine. So what's the natural, pes planus I think has a very reasonable natural history. What's the natural history of a pes cavus foot? And when you talked about pes cavus there, you talked about surgical options. You didn't really discuss, like you did in pes planus, the conservative options. Shouldn't you try and resist doing any surgery on a pes cavus foot unless the patient fails conservative treatment?
Yeah, both valid questions. Unfortunately, I was in an express way to fit it within 10 minutes, so I deliberately removed all the slides which had the conservative treatment. Firstly, talking about the need for intervention at all. 1 in 7, this American Army recruit data, have flat feet, and you can live your full life. And just like you can drive a car with poor springs, if you don't take it on a four-wheel terrain, or you don't add too much weight to it passengers wise. So in that sense, lots of people can have occasional aches with strenuous activities. Once we pass our 30s, most kind of get into the work schedule and stop playing games and so on. And so the symptoms are there, but occasional, so they don't need even insoles. But the fact remains that they still have it flat. Now, the adult with cavus foot, again, the vast majority are unaware of it till even older, like say 60s or 50s, and then they start having minor symptoms, because again, it's totally compatible and you could be a world-class athlete with it. It's only when a few things happen, which I talked about. What is not mentioned in the triad is a fourth component. The Achilles is tight, and they can get Achilles symptoms, or like I said, peroneal symptoms, or you can get fifth metatarsal stress. Again, only at the ordinary person who's a housewife or who's a doctor or a professional office-based can get by with insoles. The principle of insoles being it distributes the weight. All these abnormal structures or to the foot cause excessive loading at some point, and that hurts. So the insoles merely distribute it everywhere. So in a cavus foot, for instance, you get a lot of loading in front where the balls of the toes are pushed down. So if you, and the arch and the heel, or rather the arch doesn't take any weight at all. So you basically put a molded insole, so you bring the flow to the arch and it distributes. The second way it helps is the lateral side is overloaded because of the varus. Now, provided, it's very, very, very important to first differentiate, again, like I said, with flat feet, mobile and stiff foot. In cavus feet, you have to decide whether the foot is mobile or stiff. And if it is mobile, you give a corrective insole. If it's stiff, then you give an accommodative insole. It's a fancy name for saying don't keep adding wedges on the outside to correct it. If it's stiff, it will only hurt the patient more. But if it's passively correctable, add a wedge on the outside. And if it's stiff, again, just put it in the same position, but put a molded sole so it distributes the weight.
Okay, so coming back to you again,
Yeah.
so, because what I don't want people to go away here say is that as soon as they see a cavus foot, they've got to operate on a cavus foot. So how long would you apply conservative treatment for a cavus foot until you felt you failed that and that surgery was an option, was the only option?
Well, it's not really how long, because I have a colleague who I see almost every other week or every week. In fact, he has the most horrendous, he's a surgeon, has the most horrendous cavus feet, and his shoes are like beans, and yet he's happy to live life. It's his freedom to say whether the aches bother him enough to have surgery. And I would say, depending on whether or not it's a neurological condition. If it's a neurological condition, I'll caution the patient. Leaving it alone will make it progressive to the extent that every 10 years it probably goes 2 degrees or 3 degrees more into varus. If it's one of these idiopathic, which are a huge part, like I said, 50 to 60%, then we don't know is the answer as to whether it will progress. I tell them, if you have pain, laterally, recurrent ankle sprains, come for surgery. But if they want to live a full life, I say that's fine too.
Okay. Thank you very much to all the speakers. I think the next symposium should start. Thank you.
But you will say By 4 or 6, he'll say, I can't feel it, doctor. So this is how, you sort of examine for loss of sensation. We have validated this against, in this paper published in Practical Diabetes, we validated it with biothiometer, and we found it's about 95% sensitivity specificity compared to it's nothing but a 128 Hertz tuning fork. It's nothing but a 128 Hertz tuning fork with a graduation. So you're getting the QST, you're getting the quantitative sensory testing. So if you're using a 128 Hertz tuning fork, it's better you use this. It costs about 50 pounds. It's available from a company called Bailey Instruments in London or UK. Bailey, B-A-I-L-E-Y. So it is very useful, can be put in the coat pocket, and you can still go about examining. Of course, this is what Srijit was saying. We published in a postgraduate medical journal. In an air-conditioned room like this, it's not very much air-conditioned actually, it's quite warm. But in a good air-conditioned room, you have a metallic end and a wooden end, and you are examining the C fiber actually. Again, you're keeping it, tell the patient, are you feeling the wooden part? Then keep the cold part, the metallic part, and ask him, do you feel the difference? You don't need that test tube of hot water and cold water and all that. And if the patient can feel it, we again validated it against the biothiometer. We found a good specificity and sensitivity. This cost about 30 pounds, I think, in the UK. But it's better, as Dr. Srijit said, you have more than one test because your sensitivity will improve if you use 2 tests instead of using 1. So you can still use a monofilament, but definitely you must do a vibration. You can't do only a monofilament. And having done all these tests, why are we doing that? Because we want to make a diagnosis of a at-risk foot. If you have loss of protective sensation, absent penile pulses, a deformity, history of a foot ulcer, a patient says, doctor, I had a foot ulcer 8 years ago, and so on. The patient gives you a history of foot ulcer, any one, not all, one or more. If the patient says one of these, then definitely he's got at-risk foot, and according to the international consensus about which Srijit said, Sharat Pense is part of that guideline, you have to examine the patient every 3 months. If a person has got at-risk foot, he should come to the foot clinic once in 3 months. If he's got an ulcer, if he's got an at-risk foot. If he doesn't have any of these, then he can come once a year for a foot examination. That's what the international consensus says. Of course, the staging of neuropathy. I have only 1.5 minutes to go. I'll finish in 1.5 minutes. This Thomas Dick is a famous neurologist in London. See, if you take the stage 0, 1, 2, 3, they're all same. See, stage 1 is asymptomatic neuropathy. When you examine, you will get neuropathy. But the patient has no symptoms. Symptomatic neuropathy is when you have the same thing, but you will have minor symptoms. Doctor, I have a simple, burning sensation now and then. Disabling neuropathy is 2 or more abnormalities, but severe symptoms, can't sleep and all that. Now, most of us are examining the feet of people in this stage. In this stage, it is a dense neuropathy, no methylcobalamin, alpha lipoic acid, nothing on earth is going to work. We have to examine at this stage asymptomatic neuropathy and tell them that you have neuropathy and tell them to take care of the diabetes and HbA1c of 6.5 or whatever, not at this stage. Therefore, when you tell a patient at this stage to have their feet examined, the first excuse is retinopathy test. No, doctor, I had my glasses changed last week, doc. So why should I go for a retina test? And tell you, listen, I'm telling you about your retina, not about your glasses. Similarly, you tell about the feet. You say, doc, I have no symptoms. Why are you making me simply do this test for foot examination? You have to tell them that there's a stage 0 where you could have neuropathy but no symptoms. Stage 1, I'm sorry. So you have to treat his diabetic neuropathy at this stage, not at this stage when his nerves are all gone. Can I take another 1 minute? I've finished actually. And then you examine for foot deformities. And this is a very important slide. If you are in primary care, your history taking, clinical exam and all that is important. If you are doing research, then you should include pressure studies. You don't have to do pressure studies for everybody. How many of you have pressure studies? It's actually not needed, because if you have neuropathy and a pressure, your chances of ulceration are more. You should be doing pressure studies only if you are doing some research. Similarly, nerve conduction studies also should be done only when you are doing some clinical research. You should examine for limited joint mobility, and the best way of examining for limited joint mobility is just dorsiflex the big toe, and if you can't go beyond 60 degrees, that means you have limited joint mobility. How will you examine for limited joint mobility in the hands? That you know, no? Prayer sign, that you know, yeah. But examination of the foot for limited joint mobility is by dorsiflexing the big toe, and if you can't dorsiflex 60 degrees or more, that means you have limited joint mobility, and you can see the callus here very clearly. And then this is the risk categories, the last slide. If you have diabetes, if you have never had a foot ulcer, and so on, have protective sensation, then your risk category is 0. If you have lost your protective sensation is 1. If you have PVD and all, is risk category 3. This is the risk category given by the international consensus on diabetic foot. I thank you for your attention. Thank you.
Thank you, Dr. Vijay Vishwanathan. You have shown us very simply how to very quickly and in detail examine the diabetic foot. Now we move on to the next speaker, and he'll be introduced by my co-chair.
Dr. Gansham Goyal. I think Dr. Vijay has given a very good introduction of him as a good diabetic foot specialist, and he has a lot of publications, and now he is the Vice President of Indian Diabetic Foot Society, and is a member of Diabetic Foot Study Group of European Study Group. So, Dr. Goyal, and let us hear you.
Very good morning, Chairperson sir, Dr. Paintse, from whom I learned the finer aspects of diabetic foot management a decade back. Mean to say, the person who is working since more than 3 decades on diabetic foot care, and even at that time we were not knowing Vijay, Abbas and friends. So we all are aware, or we all know, the basic principles of diabetic foot care, 3 aspects. One is adequate debridement, then adequate vascularity, and third is adequate offloading. And offloading is one of the most important aspects to reduce the pressure. You can put anything on the ulcer except the patient's weight. So offload the ulcer. So I brought the greetings from the city of Kolkata, Joy, city of Joy, the cultural capital of the country. Diabetes mellitus is a biomechanical disease, but a large number of lower extremity complications of disorder are due to biomechanical dysfunction. Since last 2 days we are listening about the biochemical issues, but not the biomechanical dysfunction. Diabetics may have altered biomechanics or present with the complication of any pre-existing neurovascular or biomechanical dysfunction. So I'm going to discuss about the different offloading modalities, then indications for each of the different offloading strategies, and what are the advantages and disadvantages of the offloading techniques. So foot ulcers generally or frequently occur on the weight-bearing areas of the foot which are subjected to high pressures. So relieving the pressures means offloading on the ulcerate area is absolutely crucial in the treatment of diabetic foot ulcer to prevent further trauma, reduce pressure and shear to the area and facilitate wound healing. So these are the common methods to offload the foot. You all are aware, bed rest, it's most unpractical. You cannot ask a patient to be on bed for 6 weeks or 8 weeks or 3 months. Wheelchair, our working place, house and roads, these are not meant to patient can move around. And the crutch assisted gait, you see it's very difficult. It will increase the pressure on the other foot and patient may fall down. Then comes the total contact cast. That's the gold standard to offload the foot ulcers. Then the felted forms, then the half shoes, and then the removable cast walkers, especially the air cast and the therapeutic splints which are there. So in offloading devices, you can divide these in 2. One is the irremovable devices, another is a removable devices. Irremovable devices is the total contact cast, TCC with window, and ITC. So this TCC and TCC with window are very good modalities. And in removable devices, removable TCC, the air cast walkers, then AFOs, ankle foot orthosis, modified footwears, and most important is the indigenous offloading techniques, especially based on the principles of Samadhan system. So about that I am going to discuss, because in the primary care level, these are one of the modalities by which you can offload the foot well and which give the very good and high rates of ulcer healings. So before selecting an appropriate offloading device, the important issue is we should involve the patient. Selection of offloading must be always undertaken in consultation with the patient to try to achieve concordance with the device, because what the patient is working, what is his the workplace and what sort of job he is doing and how he will follow and what is the economic status. All these factors to be considered before giving a offloading modalities, and even it has to be discussed in detail with the patient. So gold standard total contact cast has been the gold standard for treating non-infected neuropathic plantar surface diabetic foot ulcers. And how it is done, the cast is well molded with minimal padding, allowing total contact with the lower leg and foot. By molding casting material to the foot and leg, weight bearing forces are spread out along the entire surface of contact, thus substantially reducing the vertical force per unit area. So this is one of the example of the total contact cast. This is a fiber cast, this is a plaster of Paris cast, bilateral total contact cast, and you can see this is the total contact cast. What are the indications when you will give a total contact cast? In a non-infected neuropathic plantar surface ulcers, this is a huge ulcer with a lot of callus, because that's why it's a neuropathic ulcer. And in the acute stage of Charcot's foot, you can give a total contact cast. What are contraindication? Of course, if there is infection, then you may use, but you have to give a removal cast or bivalve cast. Then severe arterial disease, when the ABI is less than 0.5, you should not use a total contact cast. And inexperience of the clinician applying the cast, this is a very major deterrent factor in our country and other places also. There was one study I was going across. In even US, they have done a survey in 900 centers which were treating the diabetic foot. Only 2% of the clinics were using the total contact cast. This is the status in the US, so we can imagine our country. So, and the ulcer depth is more than the width, and of course other non-compliance and all these are the relative contraindications of the total contact cast. In the total contact cast in Charcot's foot, the temperature was around more than 6 degrees than the contralateral limb. A total contact cast has been given, and after 12 weeks you see the difference is total contact cast removed and patient was put on ankle foot orthosis, and this is the way you can use the total contact cast. Now about the modified total contact cast with window. So what we have done and we are doing, and you all are doing probably if using the total contact cast, you give a MCR insole, make a window. In the great toe ulcer it is there, and in the heel ulcer you make a window, and you can dress it regularly. You can apply something if you want a growth factor sometimes if needed. If ulcer is not feeling well, it's a big ulcer, then you can use it. And how you can, I will show a case presentation. Is 4 years non-healing ulcer, and age 55 years, BMI 32, grade 2 Wagner's, because there was no osteomyelitis and circulation was absolutely normal, ABI was normal. So you see, this was a total contact cast where with window. So how you can make it? This is just an example. I'm just going to show you, give you. Gloves So you see, this way you do the dressings. You have done the dressings, and after that. So you see, patient to put in prone position, then a MCR insole was put, there was a window was made, and this like this, and it has to be done. And always make sure that ankle, at the ankle and the foot angle should be around 90 degree. Otherwise patient will not able to walk. That is very important. So this is the TCC, how it has been made, and the window was made for the dressing. And the wound closure occur after 16 weeks in this patient, which was not healing since last 4 years. So this is the window walking cast, how you can use in these patients. So this is one of the paper which we have presented at IDF Montreal, where we have used that modified total contact cast with a window in healing of non-infected neuropathic plantar surface as compared to total contact cast, and we found there is a good healing rate, and it was much cheaper than what the total contact cast, because we are not supposed to remove it regularly on weekly basis or every 15 days basis, and you can watch or inspect the wound regularly and require less frequent change of cast, and we have used the growth factors in healing of this ulcer also. This is the another patient in which there was bilateral first empty head ulcers. There was a past history of great toe amputation, and this patient was a priest by his profession, but he refused to take window walking cast, which was our first choice. He agreed for removal total contact cast. So we have given bilateral total contact cast removal. We divide the cast vertically in 2 pieces, but we ensure, because the problem with the removal cast is the compliance. So we ensure the family members that patient was in ulcer since more than 2 years. He agreed to continue, and we were just phoning, our staff was phoning, is he wearing the cast or not? And he was a priest by profession. So he told, in the morning, whenever before performing the puja, I have to go for the bath and to remove the cast, and then only I will again wear the cast. And in that patient also we find the fantastic results by using this sort of removal total contact cast. 16-week closure, this was the patients in this situation. So total contact cast, then window walking cast, and removal cast. These are the 3 modalities which you can use. And on this also we have presented a paper in IDF Dubai in 2011, and we find the removal total contact cast is also a cost-effective technique on non-healing plantar surface ulcer. But of course, the healing rates are much lesser than what the standard cast is due to the compliance issue. But the patients who are in long-standing ulcer, generally they are compliant, which we understand in our practice, and we force them to go for compliance. This is a very important thing. And of course, the only one cast will be suffice for the patients who are on this offloading modality, and we put them on, if it is broken, then we repair it, so the cost come down. So this is one of the offloading techniques about which I was discussing. This based on the principle Samadhan system, ASCO offloading. And what you do, it can be practiced at the primary care level, at a village level also. Is a foam, you roll the foam and just wrap around a gauze piece and put the offloading like this, just above the ulcer and below the ulcer, and the ulcers will heal. So this is one of the system. It's a mid-foot offloading. There is also in the mid-foot, you put 2 offloadings like this, and we ask the family members to change these offloadings on regular basis after taking the bath. So this also gives us a good healing rates. And this hind foot offloading, you can give a offloading like this on the hind foot, but what we have observed, if an ulcer is more than 2 centimeters in diameter, generally these patients require total contact cast. But if it's less than 2 centimeters, then generally we offer them to go for this indigenous technique of Samadhan system, offloading systems. So this is one of the, this is small video of 10 seconds, how you will make this offloadings. So you just roll the foam, cut it, just apply it just on the, just above the ulcer and below the ulcer, and it can be used, it will be practiced by the family members. Even we teach our clinic, the family members, that how you will offload these patients, and it gives a good result. And on this, we have presented a paper in Diabetic Foot Working Group Conference in Uppsala, Sweden. The role of SK offloading on principles in healing of non-healing neuropathic plantar surface ulcer in comparison to the footwears. And we find that it's a affordable and cost-effective technique in healing of non-healing neuropathic ulcers, and it's very economical, and it can be practiced at the primary care levels also. Then about the removal cast walkers. Many different types of several designed for diabetic wound. Advantage compared to TCs, relatively inexpensive. I don't think it's inexpensive, because one removal cast walker, I think how much it costs, around 15,000 rupees. 15,000, because air cast is 15,000, and total contact cast in our country costs around 10,000. So that is not a, and protects insole, replace if worn. Of course, if the insole is worn, then you can replace it. No special training to correctly apply, and easily removed to assess debrided bath or sleep, and used in patients with infection or severe PVD, where the peripheral vascular disease is a problem. In that situation, you can use this. Then this was a study which was done, that total contact cast versus removal contact walkers versus healing shoes. It's been shown that 90% of the ulcers healed within 2 to 3 months in the total contact cast group, while 65% the removal cast and 58% the shoes. But the reason was the fewer steps than healing sandal, means total contact cast person who is wearing is walking least. So activity level was minimum. So that was one of the reasons of healing, more healings was the reason. So this is ankle foot orthosis, which we give after the, once a patient is on Charcot's foot, you have given a total contact cast. After that, then you can put a patient on AFO. Now about the preventive foot wears. So I'm going to discuss a bit about the preventive foot wears. So basic principle of the footwear is used to remove the mechanical load of the foot. This is the basic principle. And protective footwear should include footwear for both indoor and outdoor use. So important is not that you are walking in the house without footwears and out of the house with footwear. So it should be both indoor and outdoors. Then protective footwear is based mainly on accommodation. If there is a deformity, it should be accommodated. If there is a swelling, it should be accommodated. And cushioning, the foot should have a cushioning effect. And stabilization, if patient is not, foot is not stabilized, it should be stabilized. So these are the three basic principles which should be fulfilled if you prescribe the footwear. And ill-fitting shoes cause ulcers to the digits or the dorsum. This is a very, very important issue which everybody should remember. So this is the basic principle. Footwear in diabetic should do what foot cannot do. Means all these three what we have discussed, this accommodation, cushioning and stabilization. So what are the characters of diabetic footwears? It should have a white toy box, extra depth, appropriate insole, and is having rigid heel counter and rigid outsole, so the external injuries may not occur, and rocker adjust to reduce the pressures. That is very important. Then this is the guide to footwear prescriptions based on risk status. If there is a neuropathy, on top of that, if there is no deformity, no prior plantar ulcer, no callus, no high plantar pressure, then patient can wear simply sports or depth shoe with a thick insole, which reduces the plantar pressure. If moderate, if patient having some deformity or patient having high plantar pressure, then he can have a sports or depth shoe with a thick insole plus rocker bottom. So that will suffice. Deformity is there, or prior amputation is there, or plantar ulcer history of callus, all this, then customized insole, customized footwears are needed. But remember, not less than 5 or not more than 5% of the patients generally requires the customized footwears. So characteristics of a insole, ideal insole is it should be 8 to 10 mm thick. It must distribute the pressure equally over the forefront. Areas of stress isolation should be possible and should not bottom out. This is very important because otherwise the cost factor is there in our country, and should protect the high pressure areas. So these are the different type of insoles you all know. This silicone insole, this is the Plastajet triple layer insole, and this is the MCP, microcellular polymer, microcellular rubber, MCR. These are the different type of insole, and all we have found that all sort of insoles give a good pressure reduction. Out of that, if the triple layer Plastajet gives the maximum